Sorry?
It's okay, let Hamad complete what he was talking about.
Okay, no, it's fine. So what I was saying is, it's not always that people who publish papers want to cheat, isn't it? But sometimes, especially when it comes to the big pharmaceutical companies, we cannot trust everything they tell us about medications. Right? Now, Munira, what did you want to say?
As a doctor, my duty, if I know an information or bad effect from any medicine, I should tell the public and spread awareness.
But how do you know the information as a doctor?
Maybe I can see by my eyes if they doing the experiments in our hospital like this. Maybe I don't know.
Okay. Nura, do you have an answer?
Doctor, sorry for the interruption, but we can record the session right now?
Yes, I will record it now so that it's much easier, and then I'll share it with you. Is that okay? So the meeting is being recorded starting from now. Amro, did you want to comment about? So there's one issue that Munira raised, that if you are a doctor and you are aware about the bad effects of medicines, you can tell people. But how do you then tell that these are bad effects that are happening, or is it just your patient?
You can't.
Doctor, I think he mentioned something about how to know if there is something wrong, or if there is an issue. The trials that was done for a medicine is by statistics or stories, and he mentioned something about fall plot, which make which detects where if some negative like results was withheld or withdrawn from the research.
Okay, that's interesting. That's in a meta-analysis. So what he's saying there is that you take all the evidence, not just one paper, and then you put them together. It's something that we call a meta what?
Meta-analysis.
Perfect. And then using the tools that we have there, we can tell if studies with negative effects have been not published, or whether their results are not being used by the data that we have. But it's not always easy. That's one thing I want to tell you. And one of the reasons why it's important for you to be aware of this is that we don't only going around saying everything that is published, there's an agenda. But at the same time, you need to have tools to say, how trustworthy is this published material? And if you remember from Dr. Siya's lecture, there are millions of articles published each time. And all those published articles, some of them are very good, but most of them are total rubbish. And you need to go on out.
So I need to go over those researches and know what research is good and what is bad. That's what are you saying?
Well, there's always a problem that you have researchers, different researchers doing different things, and no one person knows everything. Okay.
Yeah, of course.
So there are tools that you can use to critically appraise the information that you get. Right now, it's complicated by the fact that there's a lot of fake news that's doing rounds, and people come to you and say, "My son, you are going to be a doctor. Can you tell me if I can trust this video that I got from WhatsApp?" What would be your response?
First of all, I need to watch the video, and and then if I need to collect the information from it, and I can go and compare it with trustworthy researches, and if I got if I reach a conclusion, then I reach a conclusion whether the video is trustworthy or not.
Yes, it's a difficult process. Anyway, let's hear from Hamad. Guys, I need you to start the quiz in the next 1 minute. So let's just have two more contributions. Is that okay? Hamad, we are listening.
Yes, sir. I just wanted to ask, is it true that every time you read a research paper, you should read it in a way where you automatically assume it is faulty and it is wrong, and therefore you yourself have to look at it, and then if you read it and if you see like it is reliable, if you see like the way in which they do it, and then you yourself, like say whether it is reliable or not. Like every research paper, you should come at it with a bit of skepticism, and then when you read it, if you see it's reliable, then you can use it.
Yes, in a way, that's true. And we hope that by the end of this course, you'll be able to at least give a definitive answer whether you can trust results from a research or not. There are things that you may not be able to control. For example, if they've used false data, you cannot go in there and say, you cannot be a detective at the same time. And also, it depends on your aim. Why are you reading the paper? Are you looking for a particular answer? If the answer is not, if you are just reading it to enjoy it, maybe there's no need to appraise it. One more thing is that there are tools that you can use to appraise research papers, and we'll discuss some of them during this year and the next year. I know we're running out of time now, and one thing we can do is if you want to carry on this discussion, go on the discussion board, post your comments there. We'll continuously check and see if there are any responses that are required of us and we can answer. For now, I need you to go into the TBL and start the quiz. And these are just, today we only have 7 questions, so probably 15 to 20 minutes max, you should be finished. When you are done, we'll do a discussion. Okay? So what I'll do
Okay,
is
doctor. Doctor, how can I enter the exam?
I'm going to show you now. So
Okay, thank you.
I'm going to show my screen so you can see the blackboard. So this is your blackboard when you enter. On the left side, you have the course title, announcements, modules. Within the module, you can go straight into module 1 and use one of the icons there to go into the TBL. So this icon with a Q and an A, that's for the TBL. And in there, you should be able to find the link to the quiz for today. The other option is to go straight into activities. Do you see where I'm hovering my mouse? On my left side again, open the activities and go into TBL1. If you go into TBL1, the first thing that you are seeing there is that video that we were discussing. And the next thing is week 1 TBL 2020 requires the lockdown browser. I've disabled the lockdown browser functionality in the last TBL, so you can enter straight into the TBL. Okay? So for the next 2 minutes, start on the TBL. If you have issues, immediately tell me so that we can figure them out. For this TBL, you don't need to use the lockdown browser. For the other TBLs, we may require you to use the lockdown browser because it helps you prepare for the quizzes, for the exams, which are all going to be under the lockdown browser. Okay, I've stopped sharing my screen. Start logging in. If you run into issues, just open your mic and tell me.
Doctor,
I'm listening.
are discount on my GPA?
Sorry?
I don't know how to say it. Thank you.
Badria, can you hear me?
Yes, but I don't
Yes,
know
doctor.
how to say my question.
Doc, she said that this is does this exam count on the GPA or no?
No, it doesn't. So you find that you have multiple attempts later on. You can use it for your revision, for
Okay.
preparing for your exams, but it doesn't count on your GPA.
Okay, that's it. Thank you.
No worries.
Doctor, can we ask now or we shall wait until question?
Sir, how do you see what your score was?
Huh? Hello, can you
Sir, hello, sir. How do you see what your score was?
you check in the grade under your grades, I think. Can you check under your grades?
Yeah, I found it, sir.
Perfect. And then remember, you can redo this later. Are the other people who are still working on this? Can we finish in the next 2 minutes? Because we are aiming to finish by 12:30, so others can go for their other lectures. So is 2 minutes okay? Okay, perfect. So at 12:53 we start.
Sorry, I didn't finish.
We'll start the discussion at 12:53. In 2 minutes, you should have finished the questions.
Doctor, I finished the test.
That's
But like before like I started, I did the lockdown thing and I don't know how to remove it. How do you remove it? Like
I think you need to log out of the lockdown browser.
I don't know how to do it because it's not letting me to like leave the page.
Even after you've submitted the test.
Yeah.
Well, I mean, this is not, if it's stuck or anything, just shut down the browser. Problem is, if it may lock up your computer, so be careful about the lockdown browser.
Yeah. I think after the lecture finishes, I'll try to like shut down.
Yes,
the,
it may lock
yeah.
it down for almost 1 hour. So be careful if you need to use the device for the next lecture. If it has logged you out, you may need to log into another device.
Okay.
Yeah.
Doctor, how do we know our mistakes? We cannot access the exam again.
Cannot access the exam here.
What?
Can you not see your answers for now?
I submitted and saw my grade, but I don't know. I don't know.
Okay,
I don't know how to see my mistakes.
Okay, we're going to discuss now. Okay.
All right.
Yeah, and then we'll change the settings later so that you can play around and see the answers. So everyone, let's start. So everyone is finished. If you are not finished, just tell me. Okay, so our first question concerns. Let me share my screen. Okay.
Doctor, I didn't finish it.
Can you see my screen? Oh, okay, you are not finished yet. How many questions do you need to do?
5.
Okay, so we're giving you 1 minute to finish. 12:55 and we start.
Doctor,
I can hear you.
does this exam marks are important or not?
They won't go into your GPA.
So they are not important.
The marks are not important. The exercise is the important thing.
Okay, thank you.
Okay, we're starting with question number 1. Who wants to read our question?
A patient with hypertension came to a primary health center. Which of the following physician action is not in keeping with the process of EBM? E. Prescribing the most commonly used medication.
Okay. That's one. I see there are other 2 responses who said E. Did anyone think it was, does anyone think it's any other answer apart from E? And why do you think it's E? Why not A, for
Because
example?
you should first look at the evidence before giving the patient any or the commonly used medicine.
Okay. Menatalla, I see your hand is up. Okay. Hamad, Menatalla, I hear you. Hamad, I have a question
Yes.
before you start. So what if the most commonly used medication is also the best medication?
So you need to consider every patient individually because one patient may be different to the entire population, right? So for example, if your patient may have underlying health conditions that may actually get worse due to a certain drug, which to other patients may help them. So for example, like let's just say someone has like diabetes or like HIV or something, and the treatment to his disorder is the most common treatment to his disorder is something that would make these underlying health issues extremely worse. So you'd have to take that into consideration and choose a different drug.
I hear you. Nura, I also hear you. So I think we're all on the same page. Unless there's someone who's still struggling with the question, I'm moving to question number 2. Is that okay?
Doctor,
Uh-huh.
I have a question. When you said like if the most commonly used medication is the best one or the like, yeah, so what's the answer? Should we like use it or what can we do? Like it's the best one and even the evidence shows that.
I think Ahmad's answer was very good. The most commonly may be the best, but it may not be suitable for that patient. So, for example, the patient may have certain characteristics that make them react to that medication wrongly. So, the best medication, you don't necessarily have to give that to the patient. You have to consider the other aspects of EBM. What? No, you're not doing a personal trial. So what is the best for that patient may be the second best medication, but you're not doing trial.
So I think the best way to explain it is that yes, it is the best thing. But for this patient, because of his own physical health, because of the things that he has, maybe he has diabetes, maybe he has high blood pressure. This is not the best medication for him. For anyone who does not have underlying health issues, maybe this is the best medication. But for this specific patient, maybe it is not the best medication, and maybe it will do harm to him instead of helping.
Exactly. So there's quite a few issues, and part of your thinking is that the most commonly medication is on average the best. But for this patient that is sitting in front of you, it may not be the best because of certain characteristics. It may also not be the best because the patient doesn't like it and won't take it. So you need to factor that in your decision making. Okay, guys, I'm moving to question number 2. Who wants to take this one on? Who wants to read our question?
I'll read the question.
Yeah.
A clinical sees a patient on multiple medications and has a few questions he would like to answer about the effect of the medications on different patient outcomes. How should a clinician approach these questions?
So do you guys understand the concept, the word clinician? What does it mean?
Means the doctor?
Yeah, it could be the doctor. Who else can be a clinician?
The clinical pharmacist?
A clinical pharmacist, a clinical a nurse practitioner. So that's why we use the word clinician. And again, because there are different types of doctors. The word clinician means the person who is seeing that patient. So in this case, let's read it as a doctor sees a patient who is taking a lot of medications, right? And they have different problems. Now, the question is, how do you approach this question? Someone said D, someone said B. So, Nura, do you want to tell us why you think it's B? There's quite a lot of people with...
Okay. Because we have multiple medications, and also we are looking for multiple outcomes. So we should examine all different type of medications to see their outcomes.
So how do you do a PICO that has all different types of outcomes and medications?
Well, that's the rule of C when we have like comparison groups.
So think about it. Your PICO is the intervention and the comparison. So what will happen with your PICO?
Can you just repeat the question?
Your PICO is the population. In this case, your patient represents the population, right?
Yes.
And then it has intervention, an intervention, and a comparison and an outcome. So a PICO is a research question, one research question. You can only answer one research question using a PICO. Does that make
So
sense?
do you suggest that we should like make series of PICO questions?
You could do that. What's wrong with that? What answers that?
It's A.
A. Okay. Does A sound good enough?
Yes.
So would it not be E?
What does E say?
So because this patient is on multiple medications, so would you not do a test with all the medications but limit it to one outcome? Because the patient is on all medications, but he will only have one outcome.
So bear in mind that you are a clinician. Your question is, how do I get an answer to this question? You are not doing an experiment with the patient. You have a problem. Your patient has several problems. They have diabetes, they have hypertension, they have COVID-19. Your question now is, are these the best medications for this patient? And how do you approach this? How do you structure your PICO?
Maybe we should test them separately.
Bear in mind that your PICO can only examine one question at a time. A PICO is a focused research question. It answers a research question that's clearly focused towards a comparison of an intervention and a comparator focused on an outcome. So how can you do a PICO with all the relevant medications?
Doctor, for the result to become more accurate, we should look for like one specific medication at a time, with one outcome and also one like exposure. So that will make the result more accurate.
So you do.
So my answer would be D.
One PICO for diabetes.
Yeah.
Right.
Yeah.
With the outcome that you are looking for.
Exactly.
And then you do another PICO for COVID-19.
Another medication. So each medication will have different PICO.
Okay, that sounds good. Now, there are quite a few people who are saying A. What's wrong with A?
The problem with A is that it will examine all medications together, which will decrease the decrease the amount of accuracy.
So, in fact, it's not possible to do that because what you're doing is you have a patient sitting in front of you. You want to construct a PICO, and you want to put all these in PICO, P for patient. So your patient is the same, and that's not a problem. Your intervention now becomes intervention for diabetes, intervention for hypertension, intervention for COVID-19. Yet a PICO can only contain one intervention at a time. Menatalla, I'm listening. So that's very good thinking. But remember, in doing this, you are not trying to do an experiment on the patient. All you want to know is what works for diabetes, what works.
Doctor, can I mention the other medications in the intervention or the exposure?
No, you can only do one. But I want to address Menatalla's concern, because that's an important concern for a doctor. You are going to then say, after you have your medications, you can then search for interaction between the medications. So there are established interactions that you cannot use medication A with medication B. Is that clear? So you search for your medications, but once you have your best medications, you can then search for interactions. Can I use medication A with medication B? If not, then you search your PICO, what is the best second choice that I can use? But your PICO cannot contain 3 different interventions and 3 different comparisons and 3 different outcomes in one PICO. And another thing that's important here is that you need to think in terms of you are not doing an experiment on the patient. You are looking for answers about the effect of medication.
Wait, so is it A?
So we cannot do A because we cannot we cannot examine them all together. That's the problem with A, isn't it?
Why can't you examine them all together?
Well, how do you examine PICOs together? A PICO is a question that can be answered by itself.
Doctor?
And also, go ahead.
Okay,
Doctor?
but this is our last comment before we move to the next question because we need to finish by 1:30. So maybe 2 more comments. Is that okay? Go on.
Doctor, then how is it a single medication? I don't understand. Like, where's the comparison? It's a PICO, so the C is for comparison between like one medication and another. But I don't get how is it only for one single medication?
So, for example, if your patient is taking metformin for diabetes, and your question now is you want to know whether you should change them to a newer medication, then your PICO has the newer medication versus the old treatment that they were taking. If your patient is taking hydroxychloroquine for COVID-19, but you've heard that dexamethasone has better effects, then your PICO has the intervention of hydroxy versus the comparison of hydroxy versus the intervention of dexamethasone. Okay, so how you structure the PICO depends on what the patient is on and what you think your questions. We said he has a few questions you would like to answer about the effect of these medications. So are there other medications that are better? That could be one of the questions. So before we leave this question, I just want to quickly look at this comment from Yaman. So Yaman, okay, it's from Ahmad. Ahmad, the question is asking you whether you understand the concept of PICOs. And the main concept here is that a PICO can only examine one research question at a time. You cannot examine different questions in one PICO. So in this case, your PICO, the best way to approach it is to do a PICO for each medication that you have and answer them separately. Whether your patient takes what drugs, you can then do drug-drug interactions, which you are going to learn about. All right, I'm moving on to the next question. So the answer is D there, and you can practice on it. And again, as I said before, we can keep a discussion going about some of these questions. If they are not very clear to you, we can post them on the discussion platform. Now, question number 3 talks about Dr. Hardy, who is an accomplished neurologist at the Hamad. And one of his patients, a student with epilepsy, requested to change his current medication because it makes him drowsy. And he would like to change to another medication without the side effect. Now, Dr. Hardy changed the student's medication after considering his current clinical condition and his request. Now you're being asked, what is the best decision-making process for the doctor, for Dr. Hardy? Okay, it will be based on what? So A, is it on previous experience? B, a similar case that he had last year? Or C, the briefing he received from the medical representative. I'll explain to you what medical representatives are. And conducting a small experiment on Mohamed. So medical representatives, most pharmaceutical companies, they employ people to become representatives. What these people do is they come and visit your medical practice and tell you about the current new drugs, their prices, maybe they are better than the last ones. They tell you about what the evidence says. But remember, these are people who represent the pharmaceutical companies that are selling the drugs. Okay, can we have your responses?
Doctor, I have a question.
Yep.
I know the answer is C, but like for E, is it unethical that to conduct a small experiment on Muhammad before prescribing?
Okay, everyone is almost saying C, so this we may as well discuss E. So conduct a small experiment on Muhammad. So it's not unethical to conduct a small experiment. There are ethical guidelines to conduct experiments. Your bigger question here is how does he conduct a small experiment on Muhammad before prescribing, and why? So there are two things. You can do an experiment only if there are no data at all, right? So there's a disease, a patient has a disease, there's a drug that is supposed to work, but there's no information whatsoever. Then there are grounds to do an experiment, but you'd have to do a research following guidelines that are established. In this case, the problem
C is the
yes, C works. Why though?
Because like for the first answer, his previous experience that doesn't match the evidence-based medicine, and even a similar case that he had last year, it might be like it's also like it's related to his previous experience also. But C is getting like the evidence that like can be useful for the patient. And for D, I think the medical representative, it's because it's only from one person or like it's just the experience of the medical representative of that medical.
Okay, I'm happy with that, but I want to ask you a question. Where does his experience come in? Does it not matter at all?
No, it matters, but like it's more useful to just use the evidence to get like a clear answer, or just like get more evidence that he can use to just like prescribe the medicine.
Okay.
And doctor, like there's like this like pyramid diagram where they say that like experience is the lowest kind of EBM, like evidence-based medicine. So we can't really use experience as like good enough evidence.
Okay. So he uses his experience, but it's not what he bases his final judgment on, isn't it? So
Yeah,
he has to. Now, there's another thing that I wanted to just comment on. I don't know if you asked about the small experiment, and I think what we're saying there is that he could do the experiment, but there are reasons why it's not always necessary. Most of the times the data are there. That's one. And then two, an experiment takes time. It requires you to go through several processes. And you're not going to do an experiment on a patient without their consent, without seeing from ethical authorities. So if your patient requires has an immediate need for a treatment, that's not a very good way of finding the answer, isn't it? Just one more response before we go on.
I want to ask, can the answer number B work in some cases? Like the experience can work in some cases?
Well, but remember, this is last year. So what would have happened in the last 12 months? What could have happened?
A new drug could have come out.
A new drug could have come up, isn't it? Or there could be more information about the drug that you used last year. Either that is effective or that it's not effective or that it has harmful side effects. So there's really a huge time lag there that you don't want to really depend on.
Can we combine B with C? Like
Can
we
we
did in the
combine
course?
Can we combine B with C? So you mean in his thinking, can you say, okay, I've had this case before and I've used this drug. Now can I go and do a recent review of the scientific literature? Is that what you're thinking?
Yeah, something like that.
Yes. And then he ends up at C anyway, isn't it? So I had a similar case last year. I used drug A. Now let me do a recent review of the scientific literature to see if I can still use this drug or whether there are better drugs. So he still arrives at C. But what we don't want is for him to arrive at the treatment by just using A or just using B alone. He can include them in his judgment, but he needs to do C.
Okay.
So isn't E more common than we think? Like conducting, like so many doctors, they say, okay, I'll give you this drug, and let's see how it works. If you have negative symptoms, then come back.
Yes, Ahmad, that's a very good comment. So that's not conducting a small experiment in the strictest sense. What he's doing there is that he's prescribing a medication that has been shown to work at a population level. But again, what works for everyone may not work for one individual. So go home, try it, and tell me how it feels. It's an experiment, but not in the strictest sense, because what he's simply doing is trying the medication because your patient has probably failed to resolve the problem on some established medicine. But that shouldn't be his first step, isn't it? His first step should be, the most important step should be C. And on C, then he can then say, I found that this is probably the best medication. Go home, come back to review after 2 weeks, so we can see whether the condition has changed. It's strictly not an experiment in the true sense. All right, I want to leave this question to go to number four, unless there are other questions. Yaman, your comment about trusting, I'm not sure, but we can look at it later. So I've just reflected on the answer there. Now, let's move on to question number 4. So we have Dr. Lewis, who is a lecturer on EBM, and he gave a lecture, and one of the statements, so you're being asked, what would he not say? What would he avoid to tell the doctors that he's teaching? Everyone is saying D, D, D. Why not? And why D? Why not the other responses?
Because doctor, we have said that we will avoid returning back to textbooks when we become doctors. This firstly, and all of the rest choices are suitable for this case.
Okay, so Ahmad, your answer is textbooks are not regularly updated. What else? So are they not useful? Are textbooks not useful?
No, they are useful, but sometimes they could be outdated, and we should always look for the most recent evidence.
So where do you find the most recent evidence?
Up to date.
In literature.
So up to date is your first. So there's many sources. What if you go on literature and search and find there are 15 published studies, and each one of them is telling them a different thing? What do you do?
Well, I should judge them and see which one I'm looking for. I could just construct a PICO question to see which outcome I'm looking for.
Okay. And see if it answers them. So your best source is up to date because someone has already done the work for you. If someone has not done the work, then you may need to appraise those studies to see which one is the most recent and which one is the most
because not all studies could be applied on all patients.
perfect. Now, I want to move on to the next question, unless there's anyone who has questions on question number 4. I think question number 4 is very clear. The idea there is that you must critically, you cannot use textbooks to make clinical decisions because textbooks need to be updated and they take time to update. So if you are going to do a revision of a textbook, it takes years before it is published. So most of your textbooks, if you read them, you find that it was revised about 4 or 5 years ago, or 2 years if it's actually recent. And you don't want to treat a patient using data from 2 years ago, right? So there's your answer. Number 5, we have a patient with a migraine. Now, I need you guys to just bear in mind that during this course, we may use words that are a bit new to you, right? For example, names of diseases, names of treatments. It's good that you know about them, but you should not panic once you come across a word that you are not aware of. If it's a disease, treat it as a disease and move on. Now, a patient with a migraine went to Hamad. Amro, I'll be with you just now. Because the current medication was causing her side effects. Now, the doctor decides to prescribe a new medication. Which of the following sources will provide the doctor with the highest level of evidence? Amro, do you want to comment on this? Amro?
Doctor, I want to say like why I chose the
Why you chose D? Okay, tell us.
Because first of all, we're talking about like which source will provide the doctor with the highest level of evidence, and we want to prescribe a new medication for this patient. And when it comes to medication, I think like we do randomized control trials to get to like the guy said in the video we watched in the first of this TBL, and when it comes to RCTs, the best way to get to the best decision or to the best answer is to do meta analysis and review more than one trial to get to the most right answer or the best answer the best answer for this question or this
Okay, we hear you. I hear you. Now, is there anyone else who thinks the answer should be different? Why not?
Doctor, can you differentiate between A and D? Like, what is RCTs and what is
That's
the
a
meta-analysis
very
of
good question.
RCTs?
So, is there anyone who wants to tell us the difference between A and D? Why not do A? Karim, I'm listening.
Randomized controlled trials are like the best type of experiment because they actually use the patient and use a sample size and they compare it to another group, to a control group, and then if they use RCTs and use a meta analysis on RCTs, this will give a more valid answer.
Karim, are you
Yes.
saying A is the answer?
I didn't answer yet, Doctor.
No, I'm saying D is the answer.
Okay, good. Now, can you tell us what the difference is between A and D?
Yeah, sure. So A wouldn't be the answer because A would take a longer time. You need to be able to respond quickly to the patient. That's why you can't pick A because to run the whole trial, that's gonna take time. So you base your decision off of reviews and analysis of the trials that were previously done. That's why I think it's D and not A.
Karim, what if you have data from randomized controlled trials and data from systematic reviews and meta-analysis of RCTs? What if you have those data side by side? What would you choose?
Can you go again?
So let's say you have reports, one report from RCTs and one report from systematic reviews and meta-analysis. What would you choose? So we take out the need for doing the actual trial. So there's no need for time. You have the data at hand. What would you do?
So you're
Which
saying
one would you choose?
either the systematic reviews or the meta-analysis.
You would choose the systematic review and meta-analysis.
Are you asking me like either one of them? I'm
Yes.
confused.
Would you choose A or D? Because you said A takes time. So now let's say A is already done and D is already done. What would you choose?
So you're saying if I already had done A by myself?
Or someone else have?
Okay. I'd still probably go for D.
You'd still go for D. Why?
Because you have more insight when you have reviews and meta-analysis from other professionals.
Okay. I think that was Hamad whose hand was up, right?
Sir, is it because in meta-analysis and systematic reviews, you see, it's not just one RCT. Like there are random control trials in those reviews. However, they take many randomized control trials done by many different people, many different physicians around, and they come and they kind of do a meta-analysis of all of that data. So when you look at the systematic review or meta-analysis, you have more data, and therefore you're more likely to get a more reliable view than if it's just one randomized controlled trial, and it's not really like that many people. The sample size is smaller, and all that.
Okay. I'm happy with your explanation, Mohammed. This is the last comment before we move on to the next question. Go on.
Yeah, doctor, can you give us like a definition for each one of them? Like, what is the meta-analysis of RCTs and what is RCTs like? So we can know which one.
That's okay.
We can differentiate between
yes. Them. So I'm just gonna stop sharing for now. I don't know who asked for this annotation thing. So listen, an RCT is one trial, and I think some of you have an idea where you randomly allocate people to one treatment versus the other treatment. Okay? Whereas a meta-analysis is you have put all the trials together into one basket and synthesize the results so that they'll give you one result. So consider one trial of 100 participants that has looked at a drug to see if it works, right? And then that trial tells you that the drug works. And then 2 other trials are done. And those trials say the drug doesn't work. Let's say 4 other trials have been done. The 4 trials have different results. 3 trials say the drug works. 1 trial says the drug doesn't work. Now you're faced with a problem that you cannot make a decision because you have many trials, each one of them giving different responses.
But
now,
isn't 75% is a good percent to like use this medication?
So let me tell you something. Let me give you an example. What if there's 4 trials that have 100 participants each? So the total number of participants is 400.
400,
And then the remaining trial has 3,000 participants. What do you do? Which one do you trust? Do you simply still say 75%?
No, because the number increased.
Okay. It could be different again in that you have 3 trials that have 750 participants each and 1 trial that has 2,000 participants. Now, the problem is you are forced to make a choice because you don't know what the real answer is. This is the beauty of a systematic review, in that I'm sharing my screen with one of our systematic reviews there. Can you see it?
Yeah.
Yeah, in that you can then
Yeah.
bring together all that information and summarize it, synthesize it, and come up with an overall effect size that can tell you whether the drug works or not. Bear in mind that the fact that there's a systematic review does not mean that it has a definitive answer. Sometimes the systematic review still tells you that the answer is not definitive. Okay? So I'm just showing you. So for example, if you went and searched, you would then found all these studies that are on my map. And then you are forced to make a decision because most of them have different answers to your question. Does this drug work or not? And that's the problem with answer A. Answer A may force you to make a decision based on your limited knowledge of what works and what doesn't work. Whereas answer D, someone has done this for you. Can you see what I have on my screen there? That plot
Yes,
there.
doctor.
And the purpose of that plot is that it plots all these studies and tells you what's happening. Does this work? Does this work? Does this work from this study? And then it gives you an overall pooled analysis of the effect of the study. Now, I'm going to stop sharing this screen. One thing I need you to also remember is that a meta-analysis can be done for different research questions. In this case, we are facing a research question for a treatment. And this is why the answer is a meta-analysis of RCTs, because RCTs are the best primary study designs to answer your question. But the best way is to put all the RCTs into one basket, combine their effects, and find the overall effect, which tells you whether it works or not. This is especially important in areas where there's a lot of debate about the effect of an intervention, where people are fighting, this works, this doesn't work. A meta-analysis is the answer in that case. Okay, we are sort of running out of time. I want us to move to the next question. Question number 6, and again, remember, if there are questions that you've done in any of your TBLs that you still remain with questions, post them in the discussion. Let's discuss them going forward. Now, in question 6, you've been given a question, and the question says, in children with the common cold, is oral zinc compared to nothing? Placebo means nothing. Okay? Is it effective in reducing the duration of symptoms? What type of question is this? And I've raised arm from Ahmad. Is that you? Who has raised their hand?
I'm raising my hand, doctor.
Yeah, you can tell us.
Yeah, so the answer would be B, because we have the population. Like, this is a precise question. So we have the population, which is children, and also we have the intervention or the exposure. That would be the oral zinc, yeah?
Mm-hmm.
And then we have the comparison, which is, I think, implicit in this question.
Do we have an outcome?
Yeah, reducing the duration of symptoms.
Sama, your hand is up. Do you agree with this?
Yes.
All right. Is there anyone who thinks this is any other type of question? Is it an analytical question?
Can you explain?
Why not D? Why not E? Karim?
I said it's an analytical question. Because I thought that, because from what I see, we have a population. Yeah, we have PICO, PICO. We have all of them here in this question. So that's why I said analytical question. I also.
So Karim, can I ask you a question? What type of research questions are there? What type of research questions do you know of?
Is it the analytical and the descriptive?
Is that from your lecture today?
Uh-huh.
Are you sure?
Yeah, that's what we went through. We went through the different types, and we went through background and foreground as well.
Okay, I know you went to the lecture, but did Dr. Suhyol teach you about analytical questions?
We saw the chart where it branches, and we have the.
No, they were studies, not questions.
Is that clear, Karim?
Oh, okay. Oh, yes. Oh,
Thank you,
yeah,
Noor.
yes. Okay.
So be careful, because this is how your exam comes up, and it looks so familiar, isn't it? It looks like there's something called an analytical question, but what were you taught today? Did you learn about descriptive questions? No.
No, they were studies.
So there are only two types of research questions that you were taught today, and those are, which are the two types?
Oh, sorry. Questions were background and foreground.
Background and foreground. Thanks, Aisha. And what's the main distinction between them, Aisha? Aisha?
Yes. Background questions. Wait. Let me remember. I totally forgot.
Don't worry, Salma can help you. Go on, Salma.
The background is more of a general question to increase your knowledge, and foreground question is more specific, and it contains of PICO that we studied.
What does the foreground tell you? What does it allow you to do?
To be more specific about the diagnosis I'm going to do.
Yes, Ahmad, you are right. It allows you to make a direct clinical decision. Okay? Do I give oral zinc or not? Will it work for this child? So a background question is a knowledge question. It gives you general knowledge that you can use. In people with cancer, how long do they live on a certain treatment? But a foreground question allows you to make an immediate decision about the care of patients, which takes us nicely to question number 7.
Why isn't it an experimental question again?
Did we learn about experimental questions?
No, but experimental questions, they are based on changing a one variable so we can test an experiment. And in this question, he's changing the treatment. So he's changing
So
our variable.
Ahmed, the experimental study design involves giving a patient, assigning a patient into an experiment. But that is not a research question. That is not a type of research question. Okay? It's a type of study design. I'm on question number 7, and I think everyone is happy with this. Nora, you can go on. Nora, your hand is up. Yeah.
So first of all, this is a background question because it does not follow the PICO structure, and it's very like general question, just for a general knowledge, not for a specific knowledge.
Perfect. Anyone else who thinks different? So again, be careful, because some of these answers in these questions, they come almost like they give you something familiar, and that can mislead you. And one more thing before we leave the session is that your quizzes and exams, they come almost in the same format. So this is a good way to practice for your exam, apart from the fact that the TBL allows you to really question yourself about what you have learned. So thank you so much, everyone. Have a good day ahead, and bye. If you have any issues concerning your absences, just remain behind for the next 5 minutes. Otherwise, bye to everyone else.
Okay, doctor, can I ask you a question?
I'm listening.
B and C are the same, right?
B and C are not the same. So PICO C is not a type of question. It's not a type of, it's a way of asking questions.
Like a strategy of asking a foreground question?
Yes. Think of it as a strategy of asking a clear, refined question that gives you a clinical answer to make a decision immediately.
Okay, thank you.
Pleasure. Karim, I'm listening.
Doctor, at the start, you told us that if anyone has had the problem with attendance, to let you know.
Is that the attendance issue?
Yeah, the attendance issue.
Because I have
So
two
remember, if your
presents.
attendance was absent in the last TBL session, there
No.
is no need to worry. I'm more
The
worried
lecture,
about
sir.
this session.
The lecture, doctor.
I attended, but it's not. I was marked absent.
I have two presents and an absent.
Yeah,
The absence is for the
Same.
other
Absent and the
TBLs.
present.
Sir, I have two absents and one.
Present. Yeah.
Okay, let's do one person at a time. Let's see how many people there are. Let's start with who do we start with? Who do we start with?
Can you start with me?
I have
Okay.
a question.
You can go from A
I
to
want
Z.
you to repeat something. I want you to repeat the meta-analysis, please.
Okay, I'll be with you now. Let me just sort out the presences. So Aisha, if you have two absences, were you present in the lecture?
Yes, doctor.
So
But
where is your absence?
I was marked as present and absent at the same time. I don't know why.
That's not a problem. But just double check if you are present for this TBL. That's
And
what.
also this TBL, I was marked absent.
Did you sign in? Did you check in?
I wasn't able to. It just marked me as absent when I entered.
Me too.
the
I'm
attendance.
marked as absent in both sessions.
You need to check in. Do you know how to check in?
Yes, when I
I have-
entered to check in, he marked me absent without a reason. When I entered the attendance.
If you check in, then it marks you present. It's an automatic check-in that happens. It has nothing to do with me. So you just need to be sure that you are checking in properly. Okay. Now, Aisha,
yes.
Let me check again. Can you double check on your Blackboard to make sure that you are actually not present? All right. Who else is in absence for this TBL?
Me, sir.
Is that absent?
Yeah, sir. So I have two absences. So when I opened and checked in, it said that I'm present for this lecture right now, and then I'm absent for the W1L2 and the lecture in the morning. So
The lecture in the morning is the one that we are worried about.
yeah, so I'm absent for both. So I understand that the other one was because of my TBL. That makes sense. But the morning lecture, so that's the problem. That's an issue. I've been marked absent.
Did you check in the morning?
Yeah, I checked in, but I think maybe it was I checked in. I think 10 minutes into the lecture because the link wasn't working for me, and I didn't know how to do it. Someone
It
showed
only
me.
works when you so remember in future,
Yeah.
log in and check your presence. Check in within the first 10 minutes of the lecture.
Oh, okay.
It's not open throughout the lecture. I've corrected yours. Who's next?
Thank you.
Me. Ahmed Al Shuaibi. I was marked absent twice, and I was present in the last one.
Okay, which one were you absent from?
The first August 19, W1 L2.
Okay, that's the lecture, right?
Although I attended.
Is that El Shoibi?
Yeah.
Okay. Who else?
Doctor, I was present in the lecture, although the blackboard marked me as absent.
Did you remember to check in, Yaman?
No, I did not check in.
Yeah, you need to just remember to check in the first 15 minutes, and then it closes. So once it closes, you cannot check in anymore. I'm going
Okay,
to
I'll
take.
do
it. Yeah. But I can't find your name. Just hold on. What's your surname again?
the surname.
Yeah. Okay.
Yes.
You can send it to me. I think that may be useful. But also just remind everyone that they need to check in on when it opens, and it only opens for the first 15 minutes and then it closes. Okay?
Doctor.
Yeah, so remember the different groups are not important. If you are not in TBL 1, it will mark you absent for that TBL, but that's not a problem because we'll change that to present later. So as long as you're present in the second TBL, we'll sort it out.
Doctor, I have two present and one absent. Is that normal, yeah? Or is it?
You should have two present. The absent should be on the last TBL that you are not supposed to attend, so that's okay.
That's okay. Okay, thank you, doctor. Thank you for today.
No worries.
I'm having 3 absent
Who's
for all of them. My name is El Johara.
Did you check in?
I checked in late.
Okay, so if you come in late, the attendance would have closed. You need to come in and check in every.
No, I forgot about it, doctor. I
Or-
didn't check in the first.
Okay, I think the best thing then is let me leave you as absent so that you won't forget next time.
Doctor, me